Welcome back to the second session for today. And we have, again, a great speaker, Dr. Alexis Cullen. She is a research fellow at the Institute of Psychiatry, Psychology and Neuroscience, King's College London in the UK. And she's also a senior researcher at the Karolinska Institute in Sweden. And she will talk to us about a very large longitudinal study that's been going on for over 15 years now, and especially presenting the more recent follow-up. So the study started when children were 9 to 12, and the last follow-up was when they were 17 to 21. So please welcome Alexis.
Hi everyone, thanks for joining me today, and thanks of course as well to the conference organisers for inviting me to take part in this fantastic event. Okay, so I'm Alexis Cullen, and today I'm going to present some data from the London Child Health and Development Study. This is a study that was established by Kristen Lawrence at the IOP back in 2005. And what we do here is we've been using a novel method to try and identify children who we think might be at elevated risk of developing schizophrenia in later life. So what I thought I'd do is tell you a little bit more about our strategy, whiz through some of the findings from our main publications over the past decade, and then end by sharing some new findings from the most recent assessment phase that we've completed with this cohort. Okay, so first, just to give you a little bit of a background to this study. So as I mentioned a moment ago, on CHADS, we have developed a novel method for identifying those that we think might be at risk for psychosis. And I suppose some of you are thinking, okay, why did we need another method when we already have, of course, the well-established genetic high-risk approach, which looks at offspring or siblings of patients with schizophrenia, and of course, the relatively more recent clinical high-risk strategy. So this follows help-seeking individuals, the vast majority of whom present with attenuated psychotic symptoms. Well, there are some limitations with these approaches. With the family history approach, it's one of generalizability, really. So we know that the majority of patients with schizophrenia do not actually have an affected relative with the disorder. And so that means that by studying those individuals in the family history group, we might be tapping into a sort of more genetically mediated form of illness. For the clinical high-risk approach, of course, by the time people meet criteria for clinical high risk, their symptoms are distressing and disabling to the point that they're help-seeking. Also, of course, we know now that there's quite low remission rates from the clinical high-risk state. And in fact, even people who don't go on to develop psychosis do still have quite poor outcomes in terms of comorbidities and also functional impairments. So our aim was really to try and develop a strategy that had greater generalizability than the family history approach, but that targeted an earlier illness stage than the clinical high-risk strategy. So how do we do that? Well, at the time when CHADS commenced, Kristen was working closely with Robin Murray, who of course is one of the people who first proposed the neurodevelopmental hypothesis of schizophrenia. Now, in a nutshell, what the idea behind this hypothesis is that actually the tip of the iceberg, the bit that we see, is the first episode of psychosis. But actually before that, it's hypothesized that there is a period of abnormal neurodevelopment that starts actually in very early life. So we'll all be familiar with the prodrome, which of course the clinical high-risk strategy is attempting to target. But here what we're talking about is this sort of period before that, where there are early expressions of illness and markers of abnormal neurodevelopment. And this was from information that was collected from longitudinal studies of individuals. So what we wanted to do was really try and pick up on that early phase. So see if we could find children who were having these early expressions of illness and follow them up over time. So how did we do that? Well, we know from epidemiological studies that there are a broad number of risk factors for schizophrenia. So ranging from things like obstetric complications through to urban living. Now, the thing with these risk factors is that on their own, they're associated with quite small effect sizes. So the idea was, okay, well, what if we look at risk factors acting in combination? So having to have more than one risk factor, is that better? In terms of selecting risk factors, the criteria was that actually they needed to be well-replicated antecedents of illness. And what I mean by that is things that are not external environmental risk factors, but actually things that are thought to be part of that pathway. So those early expressions of illness. There needed to be factors that occurred before or during childhood, and they also needed to be things that could be easily assessed via questionnaire, because we wanted to screen large members of the population. So there were 3 factors that met that criteria. The first was a speech and or motor delay or abnormality. So that's basically sort of delayed developmental milestones. The presence of a social, emotional and or behavioural problem. And then finally, a psychotic-like experience. So the aims of the CHAD study really were firstly to try and assess the feasibility of using a new community-based screening procedure to identify children who presented with multiple antecedents of schizophrenia. The second aim was to really follow up these children and to sort of characterise them in terms of their neurobiology and psychopathology so that we could find out a little bit more about the disease process. So what happens before the prodrome? The third aim was to try and determine the extent to which children who presented with these antecedents were in fact at elevated risk of developing psychosis and other mental health outcomes. So now I'm just going to cover some of the methodology and tell you a little bit about the sample that we ended up recruiting. So I've talked about this novel community screening procedure. Now, what that involved was actually going into primary schools. So we were recruiting from 73 primary schools across Greater London. And we adopted this school screening procedure. And what that meant is that we went into schools and we administered screening questionnaires to virtually all of the children who were in class that day. And that was because we used an opt-out procedure, which meant that the caregivers were informed beforehand, and if they wanted to, they could withdraw their child from that procedure. But it did mean that we ended up screening over 8,000 children. And then what happened was the children would give a corresponding questionnaire with a matching ID number to their caregiver, which they would then complete at home and return to us via mail. And it wasn't until we got those matching questionnaires back that we actually identified the children and were then able to approach and recruit them. So the screening questionnaire then, obviously the caregiver questionnaire included the items about the speech and motor delays. For the social, emotional and behavioural problems, we use the strength and difficulties questionnaire. So either a child or caregiver reported abnormal score. So that's in the clinical range, the top 10% on those psychopathology scales. And then for psychotic-like experiences, we had a 9-item questionnaire, and children needed to report certainly true to at least one of those experiences. We also supplemented this with medical record screening, because we're also keen to also recruit that family history group as well. So here we were looking through records from service users from the South London and Maudsley NHS Trust, looking for people with a diagnosis of schizophrenia or schizoaffective disorder who also had a child relative aged between 9 and 12 years. So using this procedure, we recruited 3 different groups. The first was our typically developing group, so if you like, a low risk control group. And these are kids who don't present with any of the antecedents of schizophrenia, and they also don't have a family history of illness, of severe mental illness in either a first, second or third degree relative. We then have the antecedent group, and these are children that present with all 3 of those antecedent characteristics that I presented a moment ago. And then finally, the family history group, And these are children with a first or second degree relative with schizophrenia or schizoaffective disorder. Now, these methods are not mutually exclusive. So we had children who were recruited via community screening, who later, when we did the FIGs with their caregivers, we found that actually they had a family history of psychosis. And then likewise, we also had children we recruited via medical records who, when they completed the screening questionnaire, we found that they presented with the antecedent triad. Okay, so how common is the antecedent triad? This is data from a review paper, so from Kristen and I, and this presents the most up-to-date data that we have. And you can see in that Venn diagram that middle triangle there, that actually 9% of children aged 9 to 12 years presented with the full antecedent triad. And this is data from 1,504 child and caregiver dyads. Up in that top right corner there, you can see the percentage of children who didn't present with any of the antecedents. That was 23%, and that was more common in girls, whilst the antecedent triad was more common in boys. Okay, so we recruited children at age 9 to 12 years and completed baseline assessments. And then we actually followed them up every 2 years throughout adolescence, with the most recent phase being completed at age 17 to 21. And you can see the range of measures that we've collected across all the time points. So we have an extensive cognitive battery, which we completed at most assessments, MRI and EEG. And we also have biological samples for measuring genetic markers and also measures of HPA axis function and inflammatory markers. So in total, we were able to recruit 112 participants. 45 of those were typically developing. 35 presented with only the antecedent triad, with another 6 children having the antecedent triad and also a family history of schizophrenia or schizoaffective disorder. And then we had another 26 children who had a family history only. And you can see here that, you know, in terms of age at screening, that's sort of fairly equal across all the groups. But children in the antecedent group were more likely to be male. Typically developing children more likely to be white, so either white British or white other. And typically developing children also more likely to have caregivers in the managerial or professional occupations. So in most of our analyses, actually, we've tended to either match on these factors, or we've adjusted for these factors. Okay, so I'd now like to just present some data from really some of the most important publications that we've had out over the past decade. So this is looking at baseline characteristics when children were aged 9 to 12, and then data from the 24-month follow-up. So our first publication was actually from my master's project, and this is looking at neurocognitive function in the antecedent group and the typically developing children. And what you can see here in red is actually the level of cognitive impairment relative to the typically developing group that the antecedent children had. So you can see that this spans across all 7 of the neurocognitive domains that we looked at. On average, the global deficit is 0.51, so moderate impairment. And the biggest deficits are in verbal working memory and executive function inhibition. And that's interesting because actually memory and executive function are the biggest impairments that we see in patients with established psychosis. The next paper was from Kristen, looking at data from EEG. So this is from an error-inducing go-no-go task. And so this is looking at responses during their error conditions. And what we can see is that the antecedent group, which is shown in the red line, they have a reduced amplitude of this error-related negativity component. And this happened even though some of the other components were intact, and actually even though they showed similar task performance to the typically developing children. And again, this is very similar, this ERN component, to what's seen in patients with established schizophrenia. The next finding was looking at brain structure. So here we were using VBM, so looking at differences across the whole brain in grey matter and white matter volume. So just small numbers here, so 20 antecedent children, 20 typically developing children. But even with those small numbers, we did find 3 clusters where there were significant differences in brain volume. So in the yellow, we have grey matter reductions in the antecedent group, and this was in the right middle temporal gyrus. But interestingly, we found some grey matter and white matter increases, and that's shown respectively in the red cluster and the green cluster. And these clusters were on the left side, and they included the middle temporal gyrus and the superior temporal gyrus, which of course are also regions which come up quite a lot in neuroimaging studies of patients with established schizophrenia. And in particular, they're related to auditory hallucinations. I just also wanted to touch on a really interesting paper. So this was where we teamed up with Elaine Walker and colleagues, and we're looking at involuntary movement abnormalities. So these are sort of in the face, these can be things like tics or grimaces. In the upper body, they can be sort of involuntary writhing or extensions of the hand and wrist. And then in the lower body, things like foot tapping and ankle flexion. And these were rated using our clinical videos, where of course they were muted and the rater was blind to group status. And the reason why these are interesting is because Elaine Walker had previously found that when you look at home videos of patients with schizophrenia, you see that there is a higher number of these involuntary movement abnormalities compared to children who go on to never develop any disorders. And we find the same thing in the CHADS cohort. So we find that the antecedent group have a higher number of these involuntary movement abnormalities in total and in the face and in the upper body. And if you look at the receiver operator curves there, actually these movement abnormalities showed really excellent ability to discriminate between children with antecedents and typically developing children. I wanted to spend a little minute talking about some of my earlier PhD work, and this was to do with stress and the HPA axis, so really rooted in the neural diathesis stress model of schizophrenia. So here we've been able to bring in the family history group because we had sufficient numbers at that point to be able to do some really nice analyses. So what you can see here is when we looked at negative life events, both the antecedent group and the family history group report that they experienced a higher number of negative life events than the typically developing children. But interestingly, it's only the children that present antecedents that are really showing greater exposure to daily stresses. So these were school-related kind of minor hassles, arguing with other peers, difficulties at home, difficulties with teachers. And on the whole, the antecedent group are experiencing these more frequently. But interestingly, they're also on average more distressed by these experiences. So they happen more often and they're more distressing. And we don't really see that in the family history group except for home-related daily hassles. However, it's a kind of different picture when we move on to salivary cortisol, which according to the neural diathesis stress model, I was really thinking we would see some abnormalities here. Now, on the left, we can see some data for the cortisol awakening response. So this sort of component of HPA axis functioning corresponds to the increase in cortisol that we all should have when we wake up in the morning within the first 30 minutes. Kind of gives us a get up and go. And interestingly, in patients with psychosis, the awakening response is blunted, so it's diminished. It's not as high as it is in healthy controls. And what we see is actually that is also true of children with a family history of illness, but it's not the case with children with the antecedents who are in the red line here. So the family history group show a blunted CAR, and interestingly, that's even more pronounced in children with a first-degree relative compared to those with an affected second-degree relative. So suggesting it might be more genetically mediated. In contrast, when we look at the data on the right-hand side, so this is diurnal cortisol now. So typically we expect this to be elevated in patients with psychosis, which is consistent with what's been found in numerous studies. And interestingly, we see no differences across the three groups. So even the family history group are not showing that increase in diurnal cortisol. And it may be that this is kind of something that comes on board a little bit later, kind of closer to the onset of psychosis. Okay, so finally, I just wanted to spend a bit of time presenting some data with some numbers that I've very recently crunched for our most recent follow-up phase when children are aged 17 to 21 years. And before I start, just kind of pleased to say that actually we've been able to maintain really good retention rates. So 83% of the sample followed up, which is pretty impressive given the time period. So first of all, I wanted to talk about putative prodromal symptoms, which we measured using the prodromal questionnaire. So what we show here in this figure is the predicted total PQ scores. So the PQ captures positive symptoms, negative, disorganized and general prodromal symptoms. And you can see in the red that it's the antecedent group who have the highest predicted total scores here. And this is from linear regression analyses that are adjusted for age at follow-up, sex and ethnicity. The family history group have slightly higher scores than the typically developing group, but they're not significantly different from the typically developing group, unlike the antecedent group. We also applied the PQ cutoff, which is a score of 8 or above on the positive scale. And this identifies children who have probable prodromal status. And you can see in the table here that about a third of the antecedent group and the family history group actually fulfill that criteria. But when we look at the logistic regression, the odds of fulfilling probable prodromal criteria 4.5 times higher in the antecedent group, which is significant, and only 2.2 times higher in the family history group, which is not significant. Next, looking at functioning. So here we're using the SOFA, so the Social and Occupational Functioning Scale, which ranges from 1 to 100, higher scores indicating better functioning. Now we see the same pattern here. So actually the antecedent group have the lowest functioning after we've adjusted for those covariates, with the family history group being intermediate and the typically developing group showing the best functioning. And you can see that it's a statistically significant difference, highly significant for the antecedent group there, even after we adjust for those other factors. Now, it's important to say, I guess, that those scores in the 70s, what we're talking about there is a kind of slight impairment in function. And actually, most of these kids are still doing pretty well. So there was only a very small number who were not in education or employment at follow-up. So just a slight impairment in functioning there. Next, I wanted to talk about clinical staging. This was something that we assessed using the CALMS measure. So I've just provided a very brief definition there of these stages. This is kind of loosely based on the work in an original publication by Stephen Wood and Pat McGorry in Biological Psychiatry. So stage 0 is first-degree relative with psychosis, but who has no current symptoms. Stage 1 is either having some mild attenuated psychotic symptoms, but which aren't sufficiently distressing or disabling to meet clinical high risk criteria, or the presence of mild to moderate symptoms on any other of the CALMS domains, but these needed to be accompanied with distress or an impact on functioning or help seeking. Stage 1B is clinical high risk criteria on the CALMS, and stage 2 is psychosis threshold on the CALMS. So we can see that the majority of children in the typically developing group don't meet criteria for any of those stages, which is, I guess, what we'd expect. And the same is true for only 30% of the antecedent group and 20% of the family history group. We've just got a very, just one participant who had a first degree relative in the antecedent group, but who had no symptoms at follow-up. All of the other people with a first degree relative did have symptoms. Then in stage 1A, actually 38% of children in the typically developing group met criteria for stage 1A, 58% in the antecedent group, 70% in the family history group. As we might expect, given that this is a community-based sample, we've got very small numbers that have actually fulfilled clinical high-risk criteria. And that's pretty equal, in fact, across all of 3 of those groups. And then just one case that had actually transitioned to psychosis threshold in the CALMs, and that was in the antecedent group. So because those numbers are quite small, for the analyses that I'm going to present, actually we've combined together those symptomatic clinical stages into one kind of group. So we're looking at who fulfills criteria for one of those symptomatic clinical stages. So in the figure here, we've got calculated the predicted probabilities of being fulfilling criteria for any of those symptomatic clinical stages. And this is the mean predicted probabilities across the groups. And you can see that the mean is higher in the antecedent group. It's a tiny bit lower in the family history group and compared to the typically developing group. When we look at the results from the logistic regression analysis, you can see that the odds of fulfilling any clinical stage are 4.85 times higher in the antecedent group, which is significant, and 3.88 times higher in the family history group, which doesn't reach statistical significance. And again, this is adjusted for those covariates I mentioned earlier. Now, in all of the 72-month analyses I've just presented, the children who fulfilled criteria for both the antecedents and the family history are actually included in the antecedent group, because that's the group we're kind of more interested in. And so what I did in sensitivity analyses is then move those children to the family history group. So now I guess we're looking at a pure antecedent high-risk group that doesn't include any children with a family history. And what you can see is that the pattern of findings for the antecedent group is pretty much the same. So all of the significant findings we found across those 4 domains before are still present. The only difference is that now in the family history group, actually we see a greatly increased odds for fulfilling any symptomatic clinical stage, and that does now reach statistical significance. Okay, so what can we conclude from these findings? I thought it'd be quite helpful to go back to the original aims of this study. So the first was to try and assess the feasibility of using this novel community screening procedure. So as I mentioned, we screened nearly 8,000 children and 1,500 of their caregivers from 73 primary schools. And what we ended up with was, just from that recruitment method, 38 children who met antecedent criteria. So, you know, a lot of investment for effectively a very small number. But I would say, you know, we've collected a wealth of data from these children and we've followed them up for a long period of time. So in that sense, it's been quite successful. Second aim to look at the neurobiological and psychopathological features. Well, that's interesting because what we've shown here is some of the features that we find in patients with established psychosis, so cognitive impairments, the EEG abnormalities, some of the structural brain abnormalities. These are present in a much sort of attenuated form when these children are only aged 9 to 12 years. So well before the onset of psychosis and well before even the prodromal phase of illness. And so that's some really important findings. Finally, of course, what happens at follow-up? That's kind of the big question. And what we've shown here is that the antecedent group, they have higher levels of prodromal symptoms or putative prodromal symptoms. They have poorer functioning, and they're also more likely to fulfill any symptomatic clinical stage. And that's not only compared to just the typically developing group, but it's also compared to the family history group, which of course is the most well-established of those risk groups. And I suppose I'd just like to point out that, you know, it doesn't look like that's because we've recruited this kind of super healthy, typically developing group, and it's them that we're comparing to. Because remember that actually quite a substantial proportion of the typically developing group met criteria for stage 1A at follow-up. And so it's even relative to that group that the antecedent triad is conferring risk. Okay, so of course there's some limitations with the study, first being the small sample size, of course issues with generalizability. This is an inner city London population. We don't know how it would generalize to other settings. And I suppose at present, what we've looked at so far is not really the full spectrum of mental health outcomes. And we're hoping that that's something that we can do later on. You need to think about sort of the strengths of that, though, in parallel. And this is a novel approach. We have an extensive assessment battery. And as I noted, we have quite reasonable retention rates, above 80%, which I think is really fantastic. So to come back to the main question that I posed at the start of the talk, which is sort of how early can we detect youth at risk for psychosis? And I would say on the basis of these findings that maybe it's a little bit earlier than we thought. So I hope I've kind of shared some enthusiasm with you for the CHADS project. And, I think we've shown that it can be a promising strategy at identifying children who are certainly at risk for some poorer outcomes in later life. So I wanted to end by thanking some people. Firstly, Dr. Kristin Lawrence, who of course, developed the CHADS project in the first place. Helen Fisher, who joined us a little later on for the 72-month follow-up, and Robin Murray, who's been involved right from the start. My more recent collaborators, Stephen Wood, Valeria Mondelli, and Philip Maguire. Of course, we want to thank, the project coordinators, and massive thanks to the families who have participated in the CHADS project, which feels like it's been going on for a very long time. Started when, we had some very small children that we recruited, and last time I saw them, they were, everybody had shot up at university, and so we're very grateful to all these people to sticking with us for such a long time. And finally, I thank my funders. So I'm funded by the Wellcome Trust and also by Anne Narsad Young Investigator Award. Okay, so thank you, of course, to you all for listening, and I'm very glad to receive questions now.
Thank you very much, Alexis, for the great talk. I will start the questions with one which is a clarification that a couple of people have asked. So amongst others, Paul French has asked this. Hi, Alexis, great presentation. Perhaps I missed it, but why is your sample so low, 112, when I think you said you started with over 1,000 participants in the school?
Sure. So thanks everyone for listening and for your great questions, and thanks for having me. So it's a very good question, and I suppose there's quite a lot of complexity to it, so I will try and break that down. So we conducted the school screening with 8,000 children at school, but then those kids had to take home a questionnaire for their caregiver. And we didn't actually have the contact details of any of the families at all until the caregivers sent us back their questionnaire. So out of the 8,000 children that we screened, 1,500 of the caregivers sent us back a corresponding questionnaire, which we could then match up. And out of those, only 850 of the caregivers said, okay, here's my corresponding questionnaire, and yes, you can contact me about future research. So that takes us down to 850. And then out of those people, we actually approached about just over 220 families, because that was all the resources that we had to contact. And from the 220, 112 families agreed to participate. So this kind of increasing steps of diminishing people, unfortunately. But yeah, the stumbling block was really getting the caregivers to send us back those corresponding questionnaires, and then those families agreeing to be contacted for future research.
Yeah, which nicely brings us to the next question, which is from Anne-Marie Saint-Germain. Did your team follow up with the caregivers to increase response rates? And do you believe that it will be a bias for including only those families that accepted or were motivated to answer your questionnaires?
Of course, great question. I mean, we're clearly going to be missing out on some groups of people. Some children will not be taking those questionnaires home and giving them to their caregivers. So we lose some of those. Like I said, we didn't have any identifying information about any of the people that were any of the children or their caregivers until the caregivers sent us back the questionnaire. So we only have contact details for the ones who are motivated to contact us, and that was part of this opt-out procedure. And that was ethically the only way that we were able to screen these very large numbers of kids in school. So it was kind of a trade-off between, you know, do we get the caregiver information at the beginning and then only have such a small number of children to screen, presumably, or do we screen everybody and make it anonymized, and then we get the data from at least 8,000 children and hope that we get some motivated caregivers sending us back some questionnaires. So I think, of course, we're going to be missing out on, you know, certain groups of people. There's probably ethnic groups and SES groups that we're missing out on who, you know, aren't as well represented in our sample, and that's a real limitation.
Yeah, and there's a follow-up comment from Paul, again, Paul French, saying, I guess that, you know, it might be that the people you included were help-seeking, so maybe they're not so different from the group, from the health.
Yeah, absolutely. I think there is something to that. And I think one thing that has surprised us a little bit is, you know, looking in then typically developing kids about the rates of kind of people meeting sort of subthreshold to stage 1A symptoms suggests that even the typically developing children who were participating, there maybe was this selection bias aspect with people being motivated to want to take part and to come and attend assessments at the Institute of Psychiatry and do these things. I guess the good thing I would say is that because we have the school screening data on the 8,000 children, at least we can look at the characteristics that differ between those that did turn up and those that didn't. Whereas ordinarily without that, we're never really able to estimate kind of how representative our, you know, our samples are. So at least with that 8,000 kids, we can do that. So yeah, I do suspect there is some selection bias, but whether it's more than any other study, I couldn't possibly sort of comment.
Okay, thank you. The next question is, could you comment on the possible reasons behind the findings that there is a difference between girls and boys in the percentage of antecedents?
Yeah, sure. So, you know, one thing obviously sort of springs to mind is that we suspect that, you know, we would have expected that boys would have had a higher rate of the antecedent triad because that matches up with what we know about, certainly in the younger sort of samples, males being at greater risk for schizophrenia and psychosis. And that's been shown even more recently in a very large meta-analysis sort of confirming those findings. So I suspect it's really about that, about that the boys were more likely to be presenting with those risk factors for schizophrenia, really. So it is what we kind of expected. And that's why, you know, we have adjusted in the analyses for those things. But, you know, we're also very much aware that being male is a risk factor for psychosis. And so, you know, it's important to take that into consideration.
Okay, thank you. Next question is from Alison Paul. Thank you for your presentation. Do you have a particular stance on when the terms positive and negative symptoms are used with individuals who are at risk? Some would say that in the clinical high risk stage and before the clinical high risk, that the usage of positive and negative symptoms is not appropriate because they are specific to somebody who has already developed first episode or maybe has multiple episodes already.
Yeah, I think that's a really good question that came up kind of recently on a paper that we had accepted, and I think it's worth remembering that, you know, the prodromal questionnaire does include those negative symptoms, and I guess they are more tapping into sort of social withdrawal, and maybe it's not appropriate to label them as negative, but maybe that just makes the most sense for all of us to try and understand and to map that onto an earlier phase. And I guess the same really goes for positive. Yeah, I don't have any real strong views on it, but I think using those terms helps us all to understand how it could map on to a kind of adult with full-blown schizophrenia, really. So perhaps we should think about different language when we're assessing them in young people who are not yet at that phase of illness.
A question from me, if I may. So you talked about the cortisol levels and the fact that, you know, they were lower, and that is a finding that you also found in people who already have developed a first episode or have had multiple episodes. I was wondering whether you could comment, because you said genetics could explain it, but it could also be that being exposed to having a parent to struggle with an illness might be considered also something that has an influence on that. You might reflect on that.
Sure. So the reason why we particularly sort of thought the genetic angle might be relevant there was because we saw the abnormalities in the cortisol awakening response rather than the diurnal cortisol. And actually, there's been some work, so some twin studies showing that the cortisol awakening response is a lot more heritable than the diurnal cortisol profile, and also identifying specific genetic abnormalities or alleles that are associated with the CAR specifically. So that's why the fact that we saw the family history group showing these differences in the cortisol awakening response, but not the diurnal cortisol, made us sort of go down this route of, well, perhaps that maybe that particular thing, the blunting of the CAR, might be a sort of genetically mediated profile.
Okay, thank you. And there is actually a comment from Alison Young, strengthening your, answering in, like you did in part, Alison Paul comment. Where she says that actually from studies that she conducted and other people conducted, we definitely see negative symptoms and ultra high risk or clinical high risk. And that it's not an all or nothing, but probably, like you were saying, more a kind of continuum. So it's more a comment than a question.
Thank you, Alison.
I think those were the questions as far as I can see it. What I'd like to do is to thank you again, Alexis, for your great talk and the great presentation. And then to remind everybody that after the break, we have 3 symposia. You can choose which one you'd like to attend. And the good thing about being online is that everything is recorded. So if you find it difficult to choose, don't despair, because you can go back and follow. Now that you are registered, you can go back and listen to the other 2 sessions as well, if you wish. And everything should be up within 24 to 48 hours. So definitely by the end of the conference, you will be able to see everything there. We have a break coming up for 15 minutes, and then I'd like you to, as I said, attend your session. There are a couple of more questions popping in, Alexis, that you might want to look online and answering if you have the time. And just before we go and have the break, again, just to remind you that there is still a few places for the workshop, the lived experience and involvement in early intervention workshop, which takes place after the conference, and places are running out quickly. So if you are interested, you need to register as soon as possible. Okay, thanks again, Alexis, and thank you to Marika as well for the earlier talk. And thank you everybody for listening, and we will see you again in 16 minutes.